Welcome everybody, and welcome to this new Info Masterclass. Today we're having a lesson on the management of plexiform neurofibroma in the form of virtual case rounds where real-life case studies will be presented to you. This was an initiative of Rian Oostenbrink from Erasmus Center in Rotterdam, and also Justus Grön from the Leiden University Medical Hospital, and Karine Lasselle from Guy's Hospital in London will be showing us cases and discussing the topic. Before we start, and before I start and give Rian the floor, I need to give you instructions regarding the Q&A. You will unfortunately not be able to interact directly with the lecturers, but you can do so via the chat box or via the Q&A box. And after the presentations, you will have opportunities to ask our lecturers any question you may have. And now I think we can start. Rian, if you want to start.
Thank you, Marco, and also thank you, my colleagues who will join today. And thank you for your attendance in this webinar. So we will discuss clinical cases around the management of plexiform neurofibromas. The disclosures of us are reported here. So what we will do is a short re-update on the background of plexiform neurofibromas, and then we will discuss the cases. And we hopefully will have a nice discussion on it and end with some wrap-up and key messages. So please let me remind, we're talking about neurofibromatosis type 1, which have a specific clinical criteria, and the plexiform neurofibromas are a key presenting symptoms of NF1. The symptoms of NF1 may arise variable in time and also may not be all present in all patients, and most manifestations have a specific window when they do appear. Plexiform neurofibromas usually are present already early in childhood, but may grow and become more apparent. And in particular, the malignancies are presented in adulthood, but also may be present in younger ages. So the plexiform neurofibromas constitute the major complications of NF, present in about 50% of NF patients, either internal or visible, with or without hyperpigmentations. And the biggest issue is that they carry in themselves an 8 to 13% lifetime risk of developing into a malignancy, the MPNST. This is a small overview of potential appearances of plexiform neurofibromas from the external side, visible, but also along the long nerves internally. The symptoms of the plexiform neurofibromas may either arise from compressing on the nerves themselves, causing pain or deficit or numbness of loss of power, but also the aesthetics. And pain is an important issue because we also consider that an increase or a change in pain is a sign of malignant transformation. A lot of patients have prescription for pain when they have plexiform neurofibromas, and pain may be varying between burning or electric, from a local more to a diffuse. And either there's a discussion of the NF itself also influences the nerves causing pain, or that the pain is tumor specific where the plexiform neurofibroma may be located. And the pain may either come from compression of the nerve, but also stretching, or really damage to the axons and regeneration. And in the transformation of the plexiform into the MPNST, there may be also some kind of inflammation causing pain. And of course, the key issue is how to treat, and will resection help? And when to intervene? We know from some cross-sectional studies that growth is highest at early ages, but also these studies report continuing growth on older ages. The risk of resection of plexiform neurofibromas by surgery are, of course, the damage, so sensory loss or weakness, although they may also recover to normal. And of course, the damage of the nerve is associated where the tumor is located. So when it's resulting in a piece of a minor nerve or a cutaneous or a sensory nerve, the damage may be less or with a lower risk than if it's in the spinal nerves. In general, we say higher age, higher grade of the tumor or a larger tumor may contribute to higher risk factors. On the other hand, we know that never complete debulking is possible and there is a risk of recurrence. A short overview in a study of 120 patients, where the location in particular was in the head and neck, but also in the extremities, showed that gross total resection is only possible in a minority and often results in a subtotal resection. And there was a morbidity related to surgery reported in about 5%. Would it be different in all patients? So we may think also that pediatric patients may have a higher chance of rapid growth. And how is that then in recurrence? So the recurrence growth is probably also a bit bigger, maybe related to the location and also the level of partial resection. And in general, the goal of surgery, of course, is to protect the function, but also to reduce the residual tumor volume to be able to reduce also the risk of the MPNST. So perhaps, and that's what we will discuss in the cases as well, so when to resect by surgery, perhaps small superficial NFs, but also if there's an acute incident like an increase in pain on an acute moment or a loss of function. The other modality is the treatment by selumetinib, which has been available since a few years, although not in the routine medical treatment for all countries yet. In this nice study, they showed in 70 patients treated with selumetinib that the progression-free survival substantial was improved by treating with the MEK inhibitor. On the other hand, that's the side effect. Also, selumetinib is faced with side effects in a minority to cardiac function and ophthalmologic complications. But in a majority, well, perhaps low-grade symptoms like skin rash or diarrhea, nausea, but which side effects for the patient pose a lot of burden and may cause also the decision to stop treatment. So there is a discussion on when to do surgery versus when to treat by drugs. The drug treatment, in fact, is posed in inoperable neurofibromas, but then we also may consider what's inoperable. Does that depend on what approach is possible, but also of the experience of the surgeon? So to illustrate this discussion, and I hope I've introduced this now a bit, we will start with a first case of Karim.
Thank you, Rianne. Sorry, my internet connection, I think, is not that stable, so you'll just have to let me know if it cuts out. So just to move on, before we thought that before we go on to discuss management of plexiform neurofibromas in relation to the three modalities that Rianne has explained, so either conservative management, surgery, or using a MEK inhibitor, we just thought it would be helpful just to highlight, just to give you a little bit more information about MPNST and the risk in children and how that looks. But the main focus of this meeting is not going to be about the management of MPNST, but it's just, I guess a warning just to make you all aware. So, Can everybody see my slides? Yeah, okay. So, so this is a case of a 14-year-old boy who was known to the complex neurofibromatosis service at Guy's Hospital. He'd actually been diagnosed in infancy and was known to the oncology teams as well as the complex neurofibromatosis clinic because he had presented with visual impairment at a very young age and diagnosed to have an optic pathway glioma for which he was under surveillance. He'd completed chemotherapy but remained under both visual and radiological surveillance. He was registered severely sight impaired. He'd previously been on growth hormone analog injections because of precocious puberty. So as part of his routine surveillance imaging for his optic pathway glioma, he was identified to have an internal plexiform neurofibroma, which obviously subsequently led to more dedicated imaging of the neck. In retrospect, on looking back, this had probably been present 4 years before, but he'd only had imaging of his head and orbit, so it wasn't entirely clear. But this lesion was picked up and therefore was another lesion to watch. We know that internal plexiform neurofibromas are seen in 40 to 60% of patients, obviously increasing as children move into adulthood. So we began to watch this lesion. Didn't have any suspicious features. He had a normal respiratory sleep study. He was clinically very well. And so the decision was made to observe both clinically and radiologically. We advised the family about the warning signs for MPNST. And in the UK, we use this acronym, HELP. H stands for hard. So if a lump becomes hard, E and L if it enlarges significantly, and P if it becomes painful. Now, this was mainly internal, but nonetheless, we explained to the parents that if there were any concerns about these symptoms, to let us know. And in our clinics, we give families a card with this acronym and with our nurses' contact details. Subsequent to that, so coming up to 2 years later, he began to complain of discomfort and he'd noticed a lump appearing in his supraclavicular fossa. The pain was not particularly intrusive, managed with simple analgesia, and he had no other symptoms. And he was imaged at the point at which he started to complain of symptoms. Here are a series of scans showing from July 2020 through to January 23, and the plexiform had grown a little bit, but not significant for MPNST. So we arranged an early review because of his pain symptoms, and actually we saw him at 6 weeks. His pain was not intrusive. He wasn't really complaining of any deficit. It wasn't stopping him from doing anything. He was taking simple analgesics, but we were very concerned about the size of the plexiform neurofibroma, and it had become firm. So we arranged an urgent scan on the day he came to clinic. And this is the scan. I think you can appreciate here the very significant change in a very short period of time. So just to remind you, in January 2023, he was scanned as he was becoming symptomatic. 6 weeks later, there's a dramatic increase in size of the plexiform neurofibroma. So this subsequently led on to a PET scan. And just to let you know, so we when we do PET scans in for children with MPNST, we're looking at both the SUV max at the time of the imaging, and we also do some delayed imaging, and that's what the 60 minutes and the 240 minutes is. And we would normally in a malignancy expect to see, first of all, an SUV max of generally above 6, but it's variable, and this is why PET is certainly not a diagnostic tool for MPNST, and we would expect that to increase significantly on delayed imaging. And what you can appreciate here is there's this slight rim here of increased uptake, but actually the central part is quite black and that actually indicates necrosis, which is probably more concerning for MPNST. But if you just look at the SUV max values, you wouldn't be particularly concerned in this patient. And in fact, it was reported as indeterminate. And this again just shows you the lesion in the neck, and you can see that central area of necrosis and that rim of slightly increased uptake here. Just to give you a comparison, this is a slightly older boy who presented similarly, although higher up in the neck, with swallowing difficulties. And you can see this is what you would typically expect to see in an MPNST with a very high SUV max of 16.8. You can see in this boy the scan the PET imaging looks very different. So in the UK, we have centralized sarcoma services, and he was discussed in the London sarcoma service, and it was decided that we would proceed to an excision biopsy, so to remove as much as possible in the neck, and obviously to analyze that histologically. 2 masses were resected. And as you can see here on this slide, there's a significant number of mitoses representing high-grade MPNST, and unfortunately there were positive margins. A lymph node was taken out and there was no malignancy, and the inferior plexiform, there was no malignancy. So this led to further discussion, and it was decided to remove, there was a further component, I don't know if you remember from the scan, in the mediastinum. So that obviously involved a thoracic surgeon. So it was decided, even though that area was not suspicious for malignancy on a scan or PET, decided to remove that as well, and to have further surgery to remove what was left in the neck. The reason that was left was to avoid any further damage. In fact, he did sustain a vagal nerve, partial vagal nerve palsy, and a Horner syndrome. So the residual tissue in the neck was clear. The mediastinal aspect that did not look like it had any evidence of malignancy did show some potential malignancy, some mitoses. That was resected with clear margins. So from a surgical aspect, it was felt to be successful in that the whole tumor was resected with clear margins, but obviously it was high grade. The sarcoma team decided to go for a curative option, so treat with chemotherapy followed by proton beam therapy, which he completed towards the end of last year. Unfortunately, 4 months after he completed treatment, he presented with fever and cough. He was found to have a significant tumor recurrence on a CT scan, disease progression, and he continued to progress. And unfortunately, despite further treatment, palliative treatment, he died in July this year. So just to very briefly talk about NF1 associated MPNST. So the lifetime risk is variable reports, but I think most of us would quote a 15.8% lifetime risk. Most MPNST arise in pre-existing plexiform neurofibromas, but they can arise de novo. They can occur in any location. They can occur throughout life, but they're more common in late 20s, early 30s. And the prognosis for MPNST is poor, with a 5-year survival quoted at between 20 and 50%. This is just data from Guy's Hospital, both adult and pediatric cases. This is our 10-year survival of around 60%. And I think survival has improved over time with better knowledge and management of plexiform neurofibromas, and also more dedicated services to manage these patients. How do they present? Well, I've mentioned this acronym that we use: hard, enlarging, limb weakness, and persistent pain. So that's HELP, problems with bladder, bowel, sexual function, neurological deficits, swallowing and breathing. There's certain risk factors for developing NF1 MPNST, personal or family history, a history of other malignancy, previous radiotherapy, which we wouldn't see in children, large internal tumor burden, and that's then associated with people who have a spinal phenotype, and that's more associated with NF microdeletion, atypical neurofibroma, NF1 neuropathy. So what's the aim is complete excision, really. That's the only cure for MPNST. Discussion with sarcoma teams are essential. Sometimes low radiotherapy, and in this case, proton beam therapy was used. Chemotherapy, I don't think there's really been any significant improvements in the last 10 years in terms of management of MPNST from a point of view of chemotherapy. Surgery for accessible metastases, some novel therapy with high intensity focused ultrasound ablation, and of course, psychological support. There has been some work recently looking to see if there are any biomarkers that can be used to detect malignancy before it becomes apparent clinically using cell-free DNA. This is currently still in its infancy in terms of it's being used for. It's not being clinically applied yet. Well, certainly not in the UK. Thank you very much, and thank you to all the patients and to the Guy's hospital team and those who provided some input into these slides. I think, Rianne, we're going to go back to your cases, and we'll leave questions to the end.
Yeah, that's great. So I will switch to the presentation, and then I would like to invite Justus to present the first cases. If it's all right, it's coming in now.
Okay. So we selected 4 cases, of which the first 2 are quite straightforward cases of resections of neurofibromas, and the second 2 cases are more challenging, so we'll have some discussions about that. So the first case is a 7-year-old boy with NF1, and his mood wasn't so good lately, and he felt a lot of anger and was having pain in his right neck and his arm. Otherwise, he was doing well. He was on gabapentin for the pain, but this lump was growing a bit in time. And when we saw him, he had a lump in his neck. It was sort of soft, and it was fixed to the bottom of the muscles of the neck. He didn't have any motor or sensory deficits in his arm. Next slide, please. So on the right side, you see the MRI, which was done. Here you see preoperative MRI. You see a large nodule. It's supraclaviculaire in the lateral triangle of the neck with close relation to the brachial plexus. So to remove this lump, we went for surgery. And of course, it's very important to use very intensely the nerve stimulator to, especially in this area where it's quite busy with accessory nerve, phrenic nerve, and the nerves of the brachial plexus. And it turned out that this lump was a swelling of the cervical plexus, so the sensory branches of the cervical plexus. And it could be removed in total. And the post-operative MRI is on the right side. And at follow-up, at the next slide, we see him at 15 years old, and he didn't have a regrowth of this lump. And next to his ADHD is doing quite well. So the second case is a 16-year-old girl, also with NF1. And she had a growing neurofibroma since a couple of months, with no pain, but especially mechanical complaints when she wanted to lift her arm or to when she wanted to type something. It was difficult because it was in the way. It bumped against the clavicula, and that caused her pain and discomfort. So the MRI was made in Rotterdam. Also a PET scan was made, and it showed low SUV values. And on this MRI, we see a lump quite large, and it's just below the minor pectoral muscle, with close relation to the brachial plexus, which you can see just behind, just posteriorly of the lump. So we discussed with her what the treatment options are. Well, we thought we could do surgery without any functional loss, so that's what we went for. Yes, next slide. And this lump could be removed. It was growing from one of the pectoral nerves, and it could the nerve could be spared, and the lump could be taken out without any functional loss afterwards. So these are somewhat, you could say, success stories of resection, and of course it's not always like this. So we go to the third case, which is a 5-year-old boy, NF1 again. Now we're in 2014, so it's 10 years ago. We selected 2 cases which were long follow-up, which we thought it would be very interesting to see how these children go through time. So this guy was 5 years old when he was in 2014, and he had especially some mechanical complaints of swelling on the left side of his neck, a supraclavicular swelling, and it was growing over time. There didn't seem to be a lot of pain. He had some different sensation in his left arm, and due to the mechanical restrictions, also he showed some paresis of his biceps. Next slide. On the MRI, you see plexiform neurofibroma of the left brachial plexus area, also of the supraclavicular and infraclavicular locations. So because of this complaints, we went for surgery to do some reduction of the tumor load, which was quite doable supraclavicularly, where all the small lumps were going out of the cervical plexus, and with using stimulation, we could take out without functional loss part of the tumor. In the infraclavicular region, it was far more complex, and all the brachial plexus, all the lumps were growing out of the brachial plexus, and stimulation gave motor function in their hand, in his hand and arm. So there were no quiet areas to do a safe resection. So the postoperative MRI shows this, that you have some tumor reduction supraclavicularly, but infraclavicularly it's the same as pre-op. So he did quite well, and at follow-up 9 years later, he came back regularly in Rotterdam, but he came at our outpatient surgical outpatient clinic in Leiden with progressive pain in his left arm, and it was continuously, and it was very invalidating for him. He was on a lot of painkillers already, and at physical examination, he has diffuse cutaneous and subcutaneous neurofibromas. When you palpate his arm, he was very painful over the course of the radial nerve. There were multiple tumors in his upper arm, and the largest one just at the side of the brachioradial muscle, and also manipulation or painful manipulation in the supraclavicular region, although that didn't give any radiation to the arm. So MRI was made and showed some nodules next to the plexiform neurofibroma in the whole brachial plexus, and also running in all the distal nerves in the arm. And these lumps and his invalidating pain were calls for a lot of discussion in our group. So this may be a discussion we can also do here live for you. Because the problem is that his pain wasn't really related to these lumps. So maybe, Rian, you can...
Yeah, that's good. Well, because we sequentially saw the same patient at different moments. And in particular in our MDT, we discussed, could it be related? And the plastic surgeon doubted that the muscle force deficit and the pain was not directly related to the specific nerve. And that made also the decision difficult. What nerve, plexiform neurofibroma, what lump needed to be removed? And on the other hand, as well, the neurosurgeon said, yeah, if we debulk on a specific place, it will only be partial and unsure of effects on complaints. Well, in the Netherlands, we had the accessibility by the compassionate use program for selumetinib in the same years when we had this discussion. And we also considered proposed to start MEK inhibitors but then we also have a little bit discussion because usually the effect of selumetinib is evaluated at the target plexiform, and we had growing plexiform neurofibromas at different locations. So which one would have the complaint? On the other hand, we thought we had a clear outcome like pain and limited functioning. So in that sense, we decided if we would start, perhaps our outcome would be more pain reduction and improvement of functioning rather than a target PN that would reduce. So when we started treatment, there was a slight reduction on pain, but we were not able to reduce the quite substantial drug cocktail for pain he was using. We did an MRI after 6 months, and there was still growth of some PNs observed, but within the 20% limits. And I must say, in the Netherlands, we do not have access to the 3D measurement of the plexiform, so it may be a little bit disturbed. And keep in mind that we performed the MRI in 6 months after starting treatment, and perhaps the effect of MEK inhibitors may be only visible after 9 months. But on the other hand, we had to do the MRI at 6 months because he also suffered quite a lot from the side effects. So not the big side effects, so no cardiac or ophthalmology problems. Laboratory tests were normal, but he had a substantial burden of the pustulae, and also because of his socio-emotional development state, he was very focused on those pustulaes. He had recurrent paronychia, edema, leading that he couldn't wear normal shoes, had difficulty to walk. He also developed a superficial venous thrombosis, and his fatigue and his depression increased, and also due to his less ability to walk, he increased substantial body weight. And that made us finally, after 8-month treatment, to make the decision to stop the treatment due to the side effects. And we didn't have an observed reduction of tumor volume. At least after we stopped, we had an improved move and less fatigue and less edema. Although I must say, well, I think in fact, substantial change anyway on how he's doing was not observed. I think this was the end. So we go now to case 4, just to you again.
Yeah, maybe you can discuss a bit more if you have time, because
I go up.
What would in London be the next step? Do you have any ideas on it? Like, his pain was so diffuse in his whole arm and supraclavicular region. It's like not really located to the nodules you see. So if you see the MRI, I would say, okay, let's do surgery, but then what will it help for him? Do you have any suggestions?
Yeah, I mean, I think that it's very difficult, and I guess it also goes back to the previous case with the case that I presented, because what's very difficult in young people with plexiform who present with pain is actually our role as neurofibromatosis specialists is to see if we can match the symptoms to what we're seeing clinically and what we're seeing on a scan, and that can be very difficult because obviously we need to consider the mechanisms of expression of pain and the biopsychosocial model and what influences expression of pain. And what we certainly don't want to be doing is going in and taking out lumps here, there, and everywhere when actually they're not really causing the problem. And it's very much a sort of multidisciplinary team effort. So we do work with a pain specialist in our neurofibromatosis clinic, and we see in addition to medication, TENS machines. We've got obviously all the psychological techniques, psychosocial sort of support, acceptance commitment therapy, which has been well established to be effective in adults with chronic pain associated with neurofibromatosis with or without plexiform neurofibroma. And there's also various other resources that we use, such as the retrainpain.org website, etc., to try and change the sort of brain circuitry of managing the pain. So I think the problem is we don't all have the resources that we need to be able to effectively manage pain. And then when we're thinking about the three modalities, we've talked about conservative treatment, we've talked about surgery and MEK inhibitors. So in our experience, we've been using MEK for a number of years. It's been approved now for use in the UK. And when we've used it where the primary indication has been pain, it actually works very quickly. And we believe the main way in which it works is it makes the plexiforms a bit softer. So if it's not soft to start with, then it's probably not going to have much impact in terms of pain. But
that's a good remark, Karine, because we also discussed after that 6 months in that MRI if we then should continue still a little bit, because perhaps the MRI was not able to show already reduction of volume. But on the other end, then we went back, we said no, we started because of increased functionality and reduction of pain, and we said this is not the case. So that led us also to make this decision a little bit early. But I think that fits also to your remark that the pain, the effect on pain, if it is there, it probably should be earlier if you can achieve that.
So we're using, we tend to use MEK. So our main indication for using MEK is in the very young children. It's really to slow down growth, because we haven't really been convinced of any radiological, and even though we have been doing in some cases 3D volumetrics, we haven't been convinced of any significant volume reduction. But it's really in the young children to prevent growth rather than reduce volume of existing plexiform. In the older adolescents, it's really the main indication is the pain symptoms.
I think for the sake of time, I look to Marco. I think we have to switch to the second case, and then we can go also perhaps to questions of the audience. Justus.
Yeah, so this is a 13-year-old boy, and he has a large tumor in his neck on the left side with mechanical complaints, no pain, no neurological deficits. And at the examination, you see indeed a large lump on the supraclavicular side of the neck. He had a lot of complaints in his day-to-day life of this lump. He couldn't do his studies. He couldn't go do sports because his neck was fixed. So we decided to do a reduction surgery of this mass. Next slide, we see pre and post-operative MRI, where you see that the lump could be reduced for quite a bit. We again use of course, the nerve stimulator and look carefully for the accessory phrenic nerve brachial plexus. In this case, it was quite good to handle to take out a large lump of the tumor. After surgery, on the next slide, he had some growth over the years. So this was in 2014. And we followed him up with MRI scans. And in 2009, he came back and he had especially pain with sitting back, feeling discomfort at the scapula point, and where you can see on the MRI is a nodule growing over time, and that was painful. And at examination, it wasn't hard, but it was tender and firm. So we decided to do a resection of that. And on the next slide, you can see that there's in the other smaller neurofibromas, there's a bigger neurofibroma which could be easily taken out, and gave him a lot of. He was satisfied with the result of that because it gave him the most complaints at that time. Next slide. Over time, he's now 22 years old. He still noted over the years we saw a slight growth of the tumor mass again in the supraclavicular region. He had some pain with movement of his neck and scapula. It wasn't really limiting him in his day-to-day life. He went to school, obtained his bachelor's, and he went for traveling. However, it kept on growing. So next slide. We decided to do a second supraclavicular debulking, which was in June this year, which was a totally different surgery than the first time. It was doable to take out some tumor, which gave him the aesthetical result. Though it looked better now, but it's still a large mass, of course, and at least we didn't do him any harm. Like, he didn't have any neurological complaints afterwards, but the result of this surgery is far less than the first surgery was done a couple of years ago. So he's happy now at home, but we didn't do a next scan yet because it was done in June. So we can have a discussion about this approach, I think. So first, was this last surgery, was it indicated? Like, he didn't have so many complaints. He had some mechanical complaints, but no pain, no loss of function. So there was some tumor reduction, but yeah, what of course time will tell what it will end up. But maybe other choice could have been made to just wait or start a MEK1 inhibitor. What do you think?
I wondered, just as if this boy had been born 10 years later, would you have done the first surgery, or would you then have considered in retrospect as well, perhaps, to start systematic treatment?
So that's a good question, but because the result of the first surgery, I could now say, I think there was a good choice to do it then, because it really helped him for several years. Of course, it's also defendable to just start him on the MEK inhibitor and see how he responds on that.
I think it's very difficult, isn't it? And I guess, you know, decisions about watching and waiting, surgery or a MEK inhibitor, also need to be made in the context of what the young person is doing, wanting to do, and that will also change from visit to visit. So for every visit, we would always discuss all three options with the patient and the family.
Yeah.
And it's
so
very
in this
difficult.
case, it was clear something had to be done because he
Yes,
couldn't
that's right.
function only.
And
So if you see it now, you say, okay, it's only mechanical complaints, but it can be very invalidating, where you cannot move your neck. So
that's right. And I don't think, we're certainly MEK inhibitors are certainly not the sort of a magic drug treatment at all. So I think we're still left with many of these young patients where we don't really have, well, we certainly don't have any curative options, and then it's really about managing their symptoms as best we can, sometimes even with a combination approach like we've seen in this case, surgery, conservative management, and then possibly trying a MEK inhibitor.
Yeah. And you see these small nodules, no large lumps, so we're not really concerned about the atypia or progression to MPNST. But it also makes surgery, of course, more difficult, because if you have some lumps, you can say, okay, maybe you can, if there's pain at that site, you can really sort of tell them, okay, if we take that away, probably would help in the pain or the reduction of the tumor. But in this case, you sort of have to open up to see if it's stimulatable. Like sometimes it's read and it's read that it's if you have these nerve fibromas, they grow from the sensory branches of nerves, but it's not our experience. Like there are a lot of motor nerves running through that. So if you want to do surgery here, you're very careful that you don't make problems and neurological deficits.
Yeah, on the other hand, I also think that for MEK inhibitors, we also often say that the effect is on the plexiform in general also may be partial. So a part will respond and the other part not. So in that sense, it makes me also questioning when you see these kind of grave-shaped nodules, would it be logic to consider that the MEK inhibitor will affect all those areas or also just a piece? And I think this is also, we need to gain experience in what can we base our decisions also on the aspect of the structure of the plexiform neurofibroma in estimating the potential effect. I really wouldn't know yet. You're on mute, Marco.
Apologies. I have a question coming in from the audience. Thomas Brückner asks if you would treat a large or growing plexiform at a younger age to prevent symptoms later on, or only if only if they are symptomatic. And by symptomatic, he means like pain and motor sensory deficit or psychological impact from disfigurement.
Yeah. In the UK, yeah, absolutely. In the UK, we would. In fact, but from all our experience with MEK inhibitors over the years, I think our sort of main target group is really the young children with the potential for disfiguring plexiform, and you can usually tell from a young age, if a child presents at 2 and you can already see a plexiform, then that's going to be potentially trouble for them later on. So those are the young children that we're trying to target. Obviously, as soon as they're able to swallow capsules, because they have to, it's only licensed for 3 and above, and they have to be able to swallow capsules. So certainly we would absolutely, yes, in the UK. I don't know about you, Rianne and Justus. I guess it depends on availability, does it?
Yeah, well, if we set the indication, we have the availability. What I notice in the parents is also the debate on that, whether they already expect that the future will be a substantial increase, because when it's still small, there is also a little bit fear of the parents that the treatment takes long. They worry mostly about the side effects and the impact of additional controls, blood taking, etc. So what I notice is in a very young age, so below 6, even, in fact, that's the population where you're aiming for. I think when you say a small visible plexiform which has the potential to grow, you should treat. I noticed that the parents perhaps set a little bit backwards, and then after that age where we potentially think that the absolute effect on decreasing growth is already reduced, they come with the question. And I must say,
it's
it's dynamic.
It's giving them the option. I think it's most parents will be aware, and it's making them aware that this is possible. But you're absolutely right. I think the great difficulty with MEC is that although it's not obviously as toxic as standard chemotherapy, it does come with a very high burden of hospital appointments and side effects, because the skin toxicity, although obviously it's not dangerous, it can be extremely troublesome, particularly at the beginning. And you're giving a drug for which there's not going to be a noticeable effect, but you're giving a drug to prevent something happening in the future, which is of course very difficult to kind of marry, because most of the time in medicine you initiate a treatment or a surgery to reduce a symptom, but here you're preventing something from happening in the future, and there's all that uncertainty. So it's extremely challenging, isn't it?
Yeah, it's the same. I think for surgery, to propose a surgery to a parent, okay, we see that it's still small, but we can surgery is maybe easier now than it's when it's like that, as in the picture. It's almost not defendable, I think, to propose that to parents. But it might be. Of course, it's easier to do the surgery at that age.
I have a question myself, actually, because that theme of pain being a trigger to actually evaluating what to do about a plexiform seems to pop up very often in the cases that you have you have shown today. And I was wondering, and you were talking about the difficulty of actually assessing sometimes whether, what the pain is associated with exactly. And I wondered if you thought that, the current knowledge of NF1 pain, of the particular pain of NF1 patients, is well studied enough for you to actually facilitate your decision making, or that, more studies specific for NF1 patients should be done in terms of natural history and characterization of the pain.
Yeah, if I may start, I think the case 3 just showed, and we didn't put that very much forward in the case description, but it was a boy who was substantially cognitive affected, in particular in his ability to assess the nuance between a little bit pain or very much pain. I mean, if there was pain, and there was a problem. So even if you have a validated assessment of that pain, you may think if all patients with NF have all the same ability to use those measures in a valid way. But I think you very much put a point on the limitations of using pain as an outcome. Corinne?
Yeah, I mean, I agree. I think it's a really interesting topic in NF. I mean, I think chronic pain's an interesting topic in itself, but I think it's a real problem for patients with NF1, both related to plexiform neurofibromas and even in young people where there aren't any obvious plexiform neurofibromas. And I think there's a real need to have a sort of combined approach to understanding the pain, and that's working with pain specialists and also with working with psychologists to understand, to try and unwrap this sort of the biopsychosocial model and what are the drivers of pain and what influences expression of pain. Because I think until we can fully understand that, I think in terms of what we're offering as clinicians may be fairly limited, and we're only really dealing with one aspect of the pain, and that's biological pain. We're not dealing with the other aspects. And we know that young people with social communication disorders express symptoms that of express pain in a different way. It may be pain meaning that they're struggling in other ways, and I think until we fully incorporate that into our clinics, I think we're only really scratching the surface.
Yeah, I think we described the 3 modalities: wait and see, surgery, and systemic treatment. But definitely in the wait and see approach, there is incorporated that multidimensional treatment of pain and the need for a pain team as a first step when the pain of a plexiform neurofibroma is the first sign or the first reason to consider treatment, I think.
Yeah, so we make it a prerequisite for children who are started on MEC for pain, a prerequisite that they're under a pain clinic, and we obviously monitor using the various pain scales for improvement. Yeah.
And I was wondering, because all the cases you have shown, I mean, most of the cases you have shown today, surgery was always the first option. Is surgery still always the first option? Or are we coming to a point where, you know, AMEC or any future drug that we hope will come in as soon as possible, will become the first option? Are we still far from that?
So I'm the first to retreat when there's a better option. So I think in a lot of cases there, or for the cases we present were old cases, so there wasn't another option at that moment. I think now we would have more extensive discussion on what to do. But for reduction of tumor load, I think surgery is still a good option if you do it carefully and in the right way. And also for larger lumps to prevent MPNST, surgery is the only option still. And of course, we're waiting for new drugs and better drugs. And then please put me out of work. It would be great if we have better drugs.
Yeah, it's interesting that point about reduction of bulk to prevent, because I'm not sure that we have any evidence that reducing the bulk because prevents MPNST, because the transformation to MPNST is not dependent upon the size. I guess nor is pain. You know, there's no direct correlation between pain and size of plexiform neurofibroma. In our cohort of patients, when we looked back at all our figures, we published this in a few years ago. So the surgeries that we did I think we had about 30% surgery rate for plexiform, for our plexiform neurofibromas, and most of those were actually the craniofacial ones where reducing bulk, I guess it's easier when they're younger. And also, for example, you know, for example, if you have an orbital plexiform and it's obscuring the visual axis, obviously reducing the bulk and eyelid elevation is going to be important to try and preserve vision. I think we're more conservative in the UK in terms of, I get the impression just from attending conferences and things in terms of surgery, where there's a potential risk to do harm, or there's a potential risk of nerve damage, and particularly in young children, and particularly where there isn't a discrete plexiform, which most of the time there isn't, is there? And then the surgery is maybe reserved for if there's a superficial component to a plexiform that has a deep extent that's causing a problem, or a particular area that's bulky that is also causing a problem. But otherwise, I think we would get a surgical opinion and we would discuss in our MDT. But I think most of the time we would probably discuss either conservative management or MEC. I think for all the reasons that.
No, I agree, but if you have the growing larger nodules, I think surgery is the only option. And if it's like the more extensive smaller lumps we saw before, then it's probably not, surgery is probably not the best option at the moment. Yeah. But a growing lump is something where you can prevent further progression to a typical tumor.
Certainly better at reducing bulk than a MEC inhibitor. Yeah.
Well, I am terribly sorry to have to interrupt this lovely conversation. I'm a bit disappointed by the audience. We only had one question, just for 33 of you. I thank everybody for being here with us today, both the audience and there's a last minute question from Melissa Pirrino, who says, when you debulk and if the regrowth occurs, how long postoperatively do you see it? So I think what is meant here is that how long does it take for you to actually see the regrowth postoperatively? Typically.
Yeah, it depends. We know that in young children, 25% of volume increase can in 1 year, so that's quite fast. But it's a median. So.
And it depends on the age, doesn't it?
Of course, yeah.
So yes, terribly sorry to have to interrupt this conversation. Rianne, did you want to do a wrap up of today's class?
Yeah, so is the screen still on with the key messages? I cannot see if the audience can see it. But I think what we at least have illustrated by our group is that this discussion is needed, that there is not one direction or one choice that's always preferred, and that makes also the importance of having an MDT in your center, or at least have your colleagues that you know that you can consult for making the decision, because you have to do it by your MDT and to consider what diagnostics are preferred to identify the lumps and to identify the risk of malignancy and where to put what treatment at what moment. And I think the first case of Corinne has illustrated also the lifetime risk for the malignant transformation and the importance of careful follow-up and the clinical assessment of the plexiform neurofibromas during follow-up to understand the cause and to make those decisions for the patient in place. And then with that, I would like to finish and thank you all for your participation and also for the audience.
Thank you very much, everybody, the 3 lecturers, and of course the audience for being with us today. This masterclass is being recorded and will be posted on the YouTube site as soon as humanly possible. For you to come back to it if you want to go back to some of the slides that were presented, and if you want to share it with colleagues who couldn't be here with us today. We will also be shortly defining the next masterclasses for November and December and the months afterwards. So keep checking on our website, and more classes will come up. And with that, I'm closing this masterclass. Thank you again to everybody for being here with us today. Thank you.